Welcome to Healthcare Rewired, the podcast that explores actionable lessons and insights on improving healthcare through digital health with leading innovators and champions. I'm your host, Mark Noble, and today we'll continue our pursuit of how to solve the access to specialty care challenge that rural communities face with none other than Karsten Russell-Wood, the Chief Marketing Officer at Equum Medical. He's also a fellow at the National Rural Health Association, and for the past 20 years, my friend and fellow telehealth veteran. Karsten, welcome to the show.
Mark, thanks. Really excited to be here, and it is humbling to follow somebody with Zach's expertise, but I hope to add some context and color to his commentary as I look at a nation bigger than Colorado's footprint.
Fantastic. And Karsten, thank you for that segue. This is the second part of our two-part series. And as Karsten noted, Zach D'Argonne joined us from the Eastern Plains Health Network on our last episode, where he very nicely articulated the challenges that rural health faces in attracting and retaining specialists. Things that were surprises to me with regard to things like housing being a key element, spousal satisfaction, those types of intangibles. In addition to that, some of the real hard financial piece of it, which is how do you actually afford to hire a specialist with the sometimes very low volumes that these rural hospitals have. And when we got around to talking about what the answers were to some of these challenges, what the options were that they had, they really only had two models, Karsten. One was to get the hospitals together to be able to buy a specialist locally and have them timeshare between the different spaces physically, or go the telehealth route. Both of them are shared services, but for those in our audience, Karsten, that may not be familiar with shared services telehealth programs, can you describe and lay out for us what a shared services program looks like and what the keys are to making them work for rural health?
Sure, Mark. And maybe I should start with what a shared services model is, right? And so ultimately, when we look at rural hospitals, we know, as Zach pointed out, exactly what they're missing, right? They are unable to recruit the right specialists. And many times there's an imbalance between the volumes those hospitals have and the requirements for a full-time specialist. Even though if the clinical need is real, we're just not seeing the volume. And that by itself is going to have a path of diminishing return, because without the specialty access, you're going to see more transfers, you're going to see more boarding. And Zach makes a really good point. As we lose patients, we also lose the specialists, right? Because they're going to want to work at the top of their license, and they're not able to do that. So what is shared services? And to me, I actually look at how we're enabling it through telemedicine and telehealth. And reality is, we want shared services to be just like any clinical service line. And we want to optimize that service based on what the hospital needs are. Ultimately, as we just expressed, those hospitals don't need a full-time resource. So how can we bring together hospitals and deliver the right level of capacity and support based on specialist services that they need? When we look at a single hospital, they may have seasonal or fractional need for infectious disease or psychiatry. And only when we're able to bring more hospitals like that hospital together do we finally get to achieve a one-to-one ratio where hiring in a provider is necessary. Well, the reality then is the same reality as being a critical access or rural hospital in a care desert in the first place, which is access to that specialist. And physically, if we were going to try and deploy a shared services model, that specialist is spending a lot of time on the road. And I've seen this firsthand in the Northeast, in the Midwest, where if you need a neurological consult and the neurologist is there on a Wednesday, and then perfect. But, if you're coming in on a Thursday and he won't do his rotation back through for a while, you're going to see that affect the care outcomes. So how can we apply digital health and telehealth to support that access to care regardless of geography. Well, that's what a virtual fractional specialist care model does. It
Hmm.
allows us to look at the data, analyze transfers, analyze admissions, and design a specialty pot of resources that's perfectly, set from a volume standpoint, from a durability standpoint, and a scalability standpoint to support one hospital or tens of hospitals to be able to get the care they need at the scale they need.
That's awesome. So that directly gets to the core challenges that he was talking about. Now, delivering a program like that is different, particularly when you're going into a rural health network. It's different than when you're delivering services into a health system, right? And that you now have these multiple entities, each of which has their own governance models and so on and so forth, each of which has their own health IT infrastructure and that sort of thing. What are some of the challenges that you, as the service providing organization, end up facing in trying to deliver a model like that?
Well, you know, I'll say the first challenge is change. We
Yeah.
have to all come to this problem and this challenge with the goal of creating change. And, what I will always respect rural hospital administrators for is eh, no rural hospital administrator is lacking commitment or creativity to develop new programs to make sure that care can stay local. At the same time, change is hard. And we have to make sure that as we develop these new models of care, we keep a simple workflow for those frontline clinicians, especially in the emergency departments. And we also have to build trust between the local teams and these virtual specialists that could be coming in from many, many states away, all US based, but still, different backgrounds, right? So to me, I think those challenges, coupled with a network that might have different EMRs, hospitals that are still going to have to do their individual credentialing, IT leaders that need to synchronize how data will be shared and how data will be integrated, and of course, just, local protocols and behaviors. We have to bring all that together and make sure that we make these changes happen in a very transparent way and in a stepwise fashion so that we can celebrate the small wins
Mhm.
and build on those with an executive sponsor that's championing the cause.
So that's interesting, Carson. Given those challenges and the breadth of those challenges, can you share with us a little bit about the approach to solving those challenges and how you go about actually getting folks on the same page and getting their infrastructure to talk to each other and making sure that everybody is getting what they need out of the shared services program?
Sure. And for that, I think we have to begin with the problem, right? And that problem is as Zach has recalled, a problem of economics, right?
Yeah.
How do we make sure that the value we're bringing to the hospital through shared services is creating value for that community? And that community's value will be underpinned by such variables such as reduced transfers,
Hmm.
more patients being able to access care at home, uh, better inpatient admissions, right? We want to have more patients available there to go to the hospital and have care provided to them in their community. That's why hospitals are such a foundation of all rural communities across our nation. And lastly, we want to make sure that, bringing these higher acuity patients to hospitals and allowing them to stay is also supporting that high acuity confidence in the local care team to be able to care appropriately for those patients. So we really start by understanding what are the types of patients that those hospitals are losing. We can get that data through much of their admissions information, some of their financial retention information. And once we achieve that, we have a really good understanding of what type of mix of specialties we need. And, you know, one hospital may need 25% of a full-time cardiologist. However, as we have 3 or 4 more hospitals come together, we now see success in having a single full-time cardiologist. And so we can actually pivot and adjust those levels to make sure it's right-sized for that community. And that community can be a region with multiple hospitals in a rural health network or clinically integrated network, or it can be an individual local hospital.
Got it. Yeah, and we've seen in other uh, networks and such the challenge with some of the data flow and such. We've been able to get man in the middle type architectures in place that will help facilitate the aggregation of that data or the flow of that data, I should say, from the different repositories, so that the remote service provider is able to have a single pane of glass and not have to go through all that logging into different systems and so on and so forth, which I think becomes important when it comes to scale. Is that a fair assumption?
I think it's certainly important to scale, but at the same time, also it's going to be invaluable to performance. The luxury of being able to monitor and care for patients across multiple hospitals is then the opportunity to benchmark and help each hospital work better and identify areas of care where they may be having a chance to improve. So being able to benchmark, really standardize, those kind of performance metrics are critical.
Yeah. And it's funny, Carson, folks get excited when they start hearing about these shared services programs and the value and benefit they can drive. And the initial reaction is typically to try to boil the ocean. But I've heard you tell people time and time again, start small. Tell me what that
Yeah.
means to you, start small, and what the implications are for the members of these rural health networks.
Yeah. I always say, we want to begin at the end in mind, right? And starting small doesn't mean thinking small. We want to make sure that we can create a reliable program around a burning platform, an area that has absolute need right now that's creating a pain point for that hospital. It could be anything from, we're seeing a rise in, a population of patients due to seasonal type of tourism, et cetera. And so we need to fill those gaps, and we need to do it to keep these patients in the community. Or quite honestly, it could be a rural situation where a local provider just says, hey, I'm retiring or I'm moving out of the community, right? So
Yeah.
we want to make sure that there's that continuity in care. Those starting points usually start by looking at the data. If we can identify, what is causing that hospital the biggest challenges in reduced admissions or avoidable transfers, then we can start building a program around it. I usually find those are summed up by uh, models of neurology, models of psychiatry and behavioral health. Those are the inpatient specialty consults that generally create the highest level of outbound transfers. So if we can build the trust, then we can create the momentum to move from a single service point to a larger service point. And when we talk about shared services and this shared services construct, starting small is not a punitive concept. You don't start small and pay big. You
Right.
start small, but through a shared services model, you actually still get the benefits of the resources you need.
Got it. Got it. So that's a great point. And you've talked a lot about the data and such, which is always important for understanding where you're at and how you want to build. Do you want to share some of the outcomes that you've seen through some of the programs that you've supported that help folks kind of understand the end game of these shared services?
Yeah, humanistically, I lived in a rural community,
Yep.
and the best thing that I see that I can share is that people rally behind the central foundation of their hospitals, and they see that they're able to have that trusted service locally. That
Yep.
really does change the dynamic of the community. We can probably quantify that through cost statistics or quality statistics or access statistics. But at first, we need to solve the problem of inequality in access to care.
Yeah.
Geography, tyranny of distance and geography should not mean that a patient cannot get the care they need where they live. And unfortunately, what we see is that is not a one-to-one equation. We cannot find the right amount of specialists to serve all of our communities. Now, telemedicine as a solution has come to maturity where there's significant demonstrable evidence that telemedicine is a positive contributor to better care locally. And so we should also be comfortable with the fact that telemedicine is entering into our rural communities, which may also mean that it's a newer technology, but we should be accepting that. One of the other points I'll make here is trust, right? We want to make sure that trust is built. And this means that while telemedicine may open the pathways to navigate, hundreds of providers nationally, we want to make sure that shared services model is designed in such a way that, day one, you get provider one. Day two, you don't get provider 50, you get provider one again. And so we really want to make sure that it's designed in such a personalized way that we have the right regional expertise, the right hospital expertise, and the right dedicated team to stay connected to those individuals. Beyond that, we're seeing on the national stage with National Rural Health Association and National Cooperative and Health Associations from a standpoint of rural health networks. Telehealth is delivering faster access to specialties, specialty expertise, fewer transfers, better ED and inpatient disposition decisions. This is clear because now we can admit higher acuity patients benefiting our case mix index. And the last is, of course, confidence. I'll go back to that. If you're a rural hospital doctor or nurse, having that higher level, specialist available to you 24/7 can really make you more confident in the care you're delivering. All of these attributes will lead to downstream stronger financial sustainability.
Yeah, and in support of what you're saying with regard to some of those outcomes, some of the programs that we've supported at VitalNet, we've seen, for example, in teleneurology, where you've got emergent cases with stroke and things like that, we've seen improved time to access by 30% by implementing program. We've seen for behavioral health, where typically it's a 67-day wait time to see a psychiatrist in most of the rural areas of the United States. We have seen that decrease to an average of 2 hours where the program's in place for these rural communities and such. And that, of course, ends up resulting in significant downstream ROI because as you were talking about the avoidance of unnecessary transfers and things like that, those all become admissions and transfers away as lost revenue for the local hospital. It's also an unnecessary expense that's carried under Medicare, which, as we know, is also taking a hit with the significant reductions in Medicare. So any place that you're able to avoid unnecessary expenses and reduce that burden is a huge help to the state and the overall safety net, if you will, for healthcare within the state. So yeah, I'm fully on board
I
with what
agree.
you said.
And, if we really simplify to the cleanest of terms, that means better upstream care means more stable, healthier patients are discharged back to the community. And ultimately, then that whole circle is being more efficient. Patients are better off. Health systems are more efficient. And we actually see that return back to our nation's rural communities.
100%. So Karsten, break it down for me. For somebody who is, one of the rural hospitals that is interested in getting involved in one of these shared services programs and such, what steps should they be taking now, and how can they access the funding that they'll need to get it off the ground?
The funding available to rural hospitals is at a once in a generation level, whether it comes through RHT funding, if it comes through HRSA, if it comes through other grants, it is almost overwhelming to see all the different ways that our federal and state governments are actioning programs and incentives to improve rural care. This should be regarded as a very positive opportunity, but it also comes with tight timelines and it comes with some confusion. And clarity, I believe, is best achieved by collaborating and working together, not only to find common ground and understanding, but also to generate the common narrative of how to respond and request participation in these grant opportunities. This common ground really can come from sharing priorities, sharing the areas that create the most strain on those communities, and working collaboratively, to do that could also need external support. And that external support is a benefit only because the external support is giving an external view of working across the country and trying to break down different state opportunities to see which best practices are working and which phase plans could be the strongest that can deliver on the outcomes intended.
Gotcha. So lining up your partners is part and parcel to making it happen. Recognizing the tight time frames, perhaps getting some help with the actual grant response and management and such is part of that. And as a fellow member of the Rural Health Transformation Alliance, I know that that's what that's all geared towards, helping folks get through that process quickly so that they can maximize the benefit of the funds that are available. Hey, Karsten, thank you so much for sharing your actionable insights with us today. And thank you to our listening audience. Join me, Mark Noble, right here on Healthcare Rewired for more insightful episodes on improving healthcare through digital health.